In this presentation, we're going to discuss drugs for seizure disorders. So, we are going to talk about seizure disorders, and mainly we will be talking about epilepsy as well. And epilepsy refers to a group of chronic neurologic disorders characterized by recurrent seizures. They're brought on by excessive excitability of neurons in the brain. Symptoms can range from brief periods of unconsciousness to even violent convulsions. And many patients that experience seizure disorders or epilepsy may also experience problems with learning, memory, and also mood. The term seizure itself and convulsion are not synonymous. Seizure is a general term that applies to all types of epileptic events. In contrast, convulsions have a more limited meaning because not all seizures will present with convulsions. Convulsion is a term that we use to define abnormal motor phenomena. For example, the jerking movements that occur during a tonic clonic type seizures. So you can see that there are different generations of seizures, types of seizures that are listed here. And this chart on 12.1 will help you to identify what anti-seizure medications are used for the different type of seizures. So I'd encourage you to go back into your pathophysiology and review the types of seizures and what the signs and symptoms are and what the manifestations are going to be. So our first question becomes, how do these anti-seizure drugs work? And we know from long-term historical research that most anti seizure drugs are going to suppress the discharge of neurons within the seizure focus, as well as suppressing the propagation of the seizure activity from the focus area to other areas of the brain. Until recently, we didn't know that these effects were achieved by 5 different mechanisms of action. It now appears that nearly all anti seizure drugs act through one of these 5 basic mechanisms: suppression of sodium influx, suppression of calcium influx, suppression of potassium efflux, the antagonism of glutamate, and the potentiation of GABA. And you can further look at this in box 21.1 in your textbook. And the next slide, we're going to go over each in a little bit more detail. Starting with the suppression of sodium influx. Before we can even talk about anti seizure drug actions, we have to understand the sodium channel physiology. Remembering that we are trying to form action potentials that are propagated through the influx of sodium through these sodium channels. These are gated pores in the cell membrane controlling our sodium entry. So, in order for sodium influx to occur or that sodium to go through the channel, we have to have an activated channel. And after that sodium enters, that channel quickly becomes inactivated. And now, in its inactivated state, no other sodium can enter. So, under normal circumstances, this inactive channel is going to quickly return to an activated state, and it's going to permit more sodium to come in, and the propagation of another action potential will occur. Now, think about the several anti seizure drugs, including phenytoin, that will reversibly bind to sodium channels while they're in this inactivated state. Well, why would we want to do this? We're prolonging the channel inactivation. The answer is by delaying that return to an active state, again, making sure that we are prolonging this inactivation, then the drug will decrease the ability of neurons to fire at higher frequency because we're basically trying to suppress the action potential from occurring. And as a result, seizures that depend on high frequency discharge will be suppressed. Now we look at the suppression of calcium influx. At axon terminals, we learned from previous lectures that we have voltage gated calcium channels promoting the transmitter release, right? So the calcium has to go into the voltage gated calcium channels in the axon terminals. And then these drugs that suppress calcium influx will block the calcium channels, suppressing that transmission. Then we have drugs that promote potassium efflux. During an action potential, the influx of sodium causes the neurons to depolarize. The efflux of potassium is going to cause that neuron to repolarize. But if we can cause more promotion of potassium efflux, then we can cause more repolarization. There is one anti-seizure drug, retigabine, also referred to as ezogabine, will act on voltage-gated potassium channels to facilitate potassium efflux. And this action potential is believed to be why the drug's ability, or why the drug has the ability to slow the repetitive neuronal firing. If we can do this, we can provide seizure control. Glutamic acid, or what we refer to as glutamate, is the primary excitatory transmitter in the CNS, and it works on two different receptors. We remember it works on the N-methyl D-aspartate receptors, or the NMDA, but it also can work on the AMP-A receptors, or the alpha amino 3 hydroxy 5 methyl 4 isozosyl proponic acid receptors. That's a lot to say. AMPA receptors. So there are drugs like perampanel, which is a AMPA glutamate receptor antagonist. There are other drugs like topiramate, which will block the actions of glutamate at the NMDA receptor. What is this going to do? The net effect is a suppression of neuronal excitation. And then lastly, we have, in talking about the potentiation of GABA, there are several anti-seizure drugs that will potentiate this action. Remembering that GABA is an inhibitory neurotransmitter that is widely distributed through our brain. If we can change the inhibition of GABA, which these drugs do, the drugs will decrease neuronal excitability, thereby suppressing seizure activity. Now, drugs that increase the influence of GABA by several mechanisms are drugs like benzodiazepine and other barbiturates, which will enhance the effects of GABA by directing the binding, or directly binding to GABA receptors. Gabapentin promotes the release of GABA, where tiagabin inhibits GABA reuptake. Vigabatrin will inhibit the enzyme that degrades GABA. Thereby, all the net effect of these drugs will increase GABA availability. The overall therapeutic goal when discussing treatment options with your patients is to decide on a medication that is going to help reduce the amount of seizures that person is having and help them to regain the ability to live a normal or nearly normal life. And ideally, we are trying to eliminate seizures entirely. However, sometimes that's not possible because of the side effects. And so we have to balance the side effects and how they are, personally being affected by those side effects, and how much or what type of medication to prescribe. Our diagnosis and drug selection is going to drive that outcome, and controlling seizures does require the proper drug. And in your textbook on table 21.1, you're going to see the different types of anti-seizure drugs that you can select from. Let's take phenytoin for an example. This is treating for tonic-clonic and partial seizures, but you wouldn't pick phenytoin if your patient was diagnosed with absent seizures. Conversely, using some medications only for absent seizures, and those medications may not treat against tonic-clonic or partial seizures. So use that list to show you and to help drive that choice. There is a drug called valproic acid, and valproic acid appears effective against all types of seizures and all forms of epilepsy. Because most anti seizure drugs are selective for only certain types of seizure disorders, you really need to match up that drug and the type of seizure by doing the appropriate diagnostic tests. In primary care, this probably is not going to be your job unless it's your specialty. Your patient will get this diagnosis from a neurologist, and many times they are getting their treatments um, from their neurologist, but you will help to maintain at times, but also being aware of these medications, what they're for, and how they interact with other primary care medications is what is important. These diagnoses are going to come with a physical neurologic exam and oftentimes lab evaluations and even EEGs. The pharmacologic management with anti seizure drugs is very highly individualized, and many patients might try several drugs before they find the one that is the most effective for them in terms of, can they tolerate the side effects and is it really working to suppress their seizure activity? If a drug fails, you have an option of treating with another anti seizure drug alone, or maybe combining the two types of seizure medications as long as it wasn't um, because it didn't, or excuse me, as long as it didn't cause side effects that were not tolerated well. And it's just because it wasn't enough medication to stop the symptoms of their seizure. To evaluate the drug, there is a trial period that is going to be needed to determine its effectiveness. And until that seizure control is certain, that patient will still be likely under the care of the neurologist very tightly until they can find what will be used for their maintenance for seizure um, suppression. You also, in conjunction with their neurologist or specialist, will have to consider safe and effective levels of that medication. So you're thinking about peaks and troughs. And also, what else are you going to monitor? So, monitor plasma drug levels. This is very helpful, especially with our tonic clonic type seizures, because these seizures can be dangerous and they can worsen if there is a delay of therapy. Maintaining a balance and even plasma level of this drug is going to be imperative so that they have enough of the medication cycling through in order to keep their seizures at bay. By adjusting initial doses on the on just the basis of plasma levels alone can be kind of tricky. But you want to make sure that you are looking both at the clinical manifestations of symptoms, but also watching the plasma levels um, in addition to. Again, many times this is managed by the neurologist and not by primary care providers. You also, though, want to help in the promotion of patient adherence, having them to realize some things that may change with their medication. So, if, for instance, they've gained weight or they've lost weight, they're having trouble sleeping, they're not eating the same, all these things um, can cause a change in the way their medication is working for them. We also want to make sure that they are using the appropriate dose, that they are using it at the appropriate time and the length of time as well, and that they're not making any changes without the recommendation of their um, neurologist or specialist. With many of the anti seizure medications, there have been an increase in suicidal thoughts and behavior. And so, this is something else that you can monitor too in terms of their overall mental health status. But helping them to remember that they need to be aware that some anti seizure drugs, like topiramate, can increase suicidality. And not all anti seizure drugs will do this, but there are quite a few. And so having that conversation with your patient is important. And then lastly, what I want to talk about is how contraception um, is considered and, the pregnancy concerns of your patients. For those patients that are not pregnant, consider what those interactions might be with their medications. In terms of anti seizure drugs, and oral contraceptives. There are 8 anti-seizure drugs that will decrease the effectiveness of oral contraceptives. So, if they really are not trying to get pregnant, they're on oral contraceptive drugs, they need to be made aware of this because there might need to be a second mode of contraception. So, you can see in your textbook that there are some drugs like topiramate, phenobarbital, phenytoin, among others that can decrease the effectiveness of oral contraceptives. Um, carbo, um, Carbamazepine is also another one of those drugs, and we're going to talk about that in more depth. Now, if it's not necessary to prescribe those drugs, it is important to advise the patient on the risks of not taking the drugs so that they understand the risk of not taking that particular um, anti seizure medication versus not taking the contraceptive. So, have that conversation with your patient. Also, know that in addition to the risk of unplanned pregnancy, there's a risk of congenital anomalies as well with anti seizure drugs. And so it's important that pregnant women with seizures take the drugs that they're supposed to, um, but they are considering, that there are two reasons for this. The risk to a fetus from a uncontrolled seizure is greater than the risk from the anti-seizure drug itself. And I'll say that one more time. The risk to a fetus from uncontrolled seizures is greater than the risk for anti-seizure drugs. And then lastly, more than 90% of women who take anti-seizure drugs while pregnant do have normal pregnancies with infants that are born to term and without problems. So, in your textbook, according to the American Academy of Neurology and American Epilepsy Society, they do recommend that you are taking folic acid in addition to taking your anti seizure medications. Something to note too is to decrease the fetal risk, avoid valproic acid unless it's absolutely necessary, and then try to use the lowest effective dose possible during the pregnancy. Medications are grouped into two major categories. We have the traditional anti seizure drugs, and then we have the newer anti seizure drugs. And they sometimes are shortened to AEDs or anti epileptic drugs. So we will refer to them as both here. You can see that the traditional anti seizure drugs are listed here, as so are the newer drugs. First, talking about the anti seizure drugs that are more traditional, they've been used for decades. And because of this, we have a lot of clinical experience and background to understand the efficacy and that therapeutic niche that we have to keep our patients in order for these drugs to work. And as a result, they're prescribed more widely than the newer drugs. We just have more information and research. Although familiarity makes traditional anti seizure drugs appealing, there are some drawbacks because they're older generation drugs. Some of them do pose greater risk to the developing fetus. They also have higher profiles for adverse effects as well. And many of them have the ability to induce or inhibit metabolizing enzymes. So they are hard to use sometimes with other drugs that your patient may be prescribed. They have a complex interaction with other drugs. And so watching out for the things like the CYP and also making sure there's no other drug to drug interactions is important for your patient. Here you can see in table 21.3 the comparison side by side of the traditional versus the newer. You can see that newer drugs are most often equally good and probably even better to some extent. It's just that we don't have enough research established yet. Clinical experience, we have less information because they are new. The therapeutic niche is still evolving. However, usually newer anti seizure drugs are better tolerated, less side effects than our traditional. So you can see here tend to be even more safer during pregnancy. The downfall is that they are more expensive than the older generation or traditional medications. We are going to talk about phenytoin, remembering that that is a traditional anti seizure medication. The way that phenytoin works, its mechanism of action is that when the concentrations are achieved clinically in the body, phenytoin will cause a selective inhibition of the sodium channels. Specifically, these drugs are going to recover sodium channels from the inactive state and move it back to the active state. And as a result, the entry of sodium into the neurons is going to be inhibited. Why do we want this? If we are able to achieve this, action potentials will be suppressed and will have, in result, a suppression of activity from seizure generating neurons. And so we can help decrease that overfiring of the neurons. It's also important to remember the capacity of the liver to metabolize phenytoin is very limited. And so, trying to understand where that threshold is for therapeutic effects is sometimes challenging. It's only slightly smaller than the dose itself that's needed to saturate that hepatic enzyme and metabolize phenytoin. So, if you are giving phenytoin in doses in whatever dose, you are considering how much that dose is causing plasma levels of phenytoin to rise. And even the little bit of increase can cause phenytoin to rise pretty dramatically. The usual relationship between dosage and plasma levels, you can see in the book in figure 21.1a. And you can see that as plasma levels reach the therapeutic range, there's only small changes in the dosage producing large changes in relation to that. And so it is a very tightly monitored drug, and watching for that increase is going to be important when considering how you're going to monitor your patient. You're going to look at plasma levels. Also, keep in mind that phenytoin can be used to treat all major forms of epilepsy except that of absent seizures. So, good for everything else, not good for absent seizures. And then also noting that this is a drug of choice for treating seizures in adults and in older children. In younger children, we might use a different drug, um, carbamazepine, which we'll talk about a little bit later on in this lecture, tends to be a more first line for younger children. Plasma drug levels are often monitored, as we talked about, and the objective is to get a level of 10 to 20 micrograms per milliliter. And anything below 10 micrograms per milliliter is going to be too low to control the seizure. So if you go and get your monitoring labs and they're not even at 10, this is not enough to create a therapeutic effect. But anything over 20 micrograms per milliliter can produce toxicity. So again, here we're talking about that narrow therapeutic range. Some adverse effects to think about are that primarily of the CNS, because it's working relatively selectively to suppress seizures. It can also cause CNS side effects, especially when you are dosing too high. At therapeutic levels, sedation and other CNS effects are pretty mild. But when you get to levels of 20 or greater, remember, we can see toxicity. And with that, we might even see changes in addition to the CNS. Nystagmus tends to be a relatively common side effect as well, in addition to sedation, ataxia, double vision or diplopia, and other cognitive impairment. And the more the patient is, the higher, the patient is with their therapeutic levels, the more prone they are to these adverse effects. You might even see gingival hyperplasia with some of your patients. This is also going to present with swelling and tenderness and bleeding gums. And in extreme cases, patients might need surgical removal of this excess gum tissue. Some of the dermatologic effects that you want to look out for is that some patients can form measles-like rashes. It can also cause Stevens-Johnson syndrome or toxic epidermal necrolysis, or TEN, T-E-N. And so you want to make sure that your patients that are higher risk for these things anyways are being told about this risk for dermatologic side effects. Other patients that have um, uh, a Asian descent, if they're from Asian descent, or they have a known genetic mutation on the human leukocyte antigen, the HLA-B1502, then this puts them at higher risk as well. And so, for this reason, phenytoin should not be prescribed to patients that have this genetic mutation. Something that you might not have heard of until now is called the drug reaction with eosinophilia and systemic symptoms. This is called DRESS, DRESS. Rarely, patients can experience these signs and symptoms of hypersensitivity with systemic involvement. And this is associated with those patients with the HLA-B1502 um, genetic profile. And what they would see, or what you would see if they are experiencing this DRESS syndrome, is lymphadenopathy, skin eruptions, fever, and they may even fall into multi organ failure. If you are seeing any of these things, then you need to discontinue the drug immediately. And then, of course, there are some effects in pregnancy. It is considered a teratogen, and so it can cause cleft palate, heart malformations. You can also see some growth deficiency and motor and mental deficiencies in babies where mothers have taken phenytoin. Microcephaly is something also that you might notice, and deformities of limbs. Cardiovascular effects can also adversely take place, especially when administered by IV injection. Cardiodysrhythmias and hypotension can result, or lower blood pressure. And it's very dangerous if these things happen, obviously, but we can minimize this risk if we inject phenytoin no faster than 50 milligrams per minute. So you definitely do not want to push phenytoin quickly. Other adverse effects are listed here, and then you can see some more in your textbook. But we did go over the large, the more common ones. Liver damage is rare, but it can occur. So, something also to think about with patients with hepatic disease. And then we need to talk about how this drug can interact with other hepatic drugs that metabolize through the CYP, and specifically the CYP2C8, the 2C9, and the 3A4 isoenzymes. We also might see some with the CYP2B6 as well, but just remember that it is a drug that you need to consider and cross reference with other hepatic drug metabolizing uh, enzymes. Other drugs that can decrease plasma levels of phenytoin, actually, alcohol, ironically, phenobarbital as well, can also decrease the levels of phenytoin. And when these levels of phenytoin are lowered, you can have a breakthrough seizure. So, take in, for instance, a patient is doing really well, but all of a sudden they're having breakthroughs with their dose that they have typically done well on, then you're looking for other reasons why those plasma levels would have decreased, and you'll get a plasma level as well. In terms of drugs that may increase the plasma level, you might see this happen when patients are taking drugs like diazepam, or maybe drugs for TB like isoniazid and cimetidine. These are all drugs that can also increase the levels of phenytoin. And I said, ironically, alcohol will decrease plasma levels, but the reason I said that is because alcohol can also increase plasma levels as well, but more so when alcohol is used acutely. It's with chronic alcoholism that it can decrease. Overall, just know alcohol and phenytoin should not be mixed together. Other depressants, such as, or depressant effects from alcohol and barbiturates, can also have adverse effects, additive effects, obviously. And then one last thing in terms of tube feedings, they will also decrease phenytoin absorption and will also lead to more subtherapeutic serum levels. So if you have a patient with enteral feeding therapy, then this is also something to consider. With carbamazepam, I'm going to refer to it now as Tegretol because that is hard to say, is the cornerstone of epilepsy therapy. It's active against partial seizures, it's active against tonic-clonic seizures. However, just like phenytoin, it's not used for absence seizures. And the way it works, or the mechanism of action, is that this drug, Tegretol, will suppress the high frequency neuronal discharges in and around the seizure focus. It's the same as phenytoin in terms of its work or its effect on the sodium channels. And we're trying to delay that recovery of sodium channels from their inactive state and hopefully delaying the amount of overfiring of the neurons. Also, something to remember with this medication, it does induce hepatic drug metabolizing enzymes as well, just like phenytoin and also just like phenobarbital. The therapeutic uses we've already talked about. Just remember again, it's not used for absent seizures. And we also know that using this medication can reduce neuralgias that are associated with trigeminal and glossopharyngeal nerve disorders. That's just a side note of other reasons you can use this medication. In terms of dosage consideration, you want to give the largest portion of the daily dose at bedtime. And this is because you're trying to reduce those adverse CNS effects. And to minimize that side effect of the medication, the dosage is going to be very low in the beginning, and you're going to increase it gradually over the next few weeks until seizure control is achieved. So you may not see any changes in seizure control for the first few weeks until you've met the dose, but you want to get there slow. Additionally, in contrast to drugs like phenytoin and phenobarbital, this medication has minimal effects on cognitive function. And this is primarily the reason why we would select this medication over the other anti seizure drugs. And I'll say that one more time. We would pick this medication over the other drugs like phenytoin and phenobarbital because it has less effects on cognitive function. But like other medications, there are some neurologic effects you might see, like visual disturbances, the nystagmus, blurred vision, and diplopia that we talked about earlier. Your patients may also experience vertigo, headache, and even ataxia. These side effects are more common during the first few weeks of treatment. And then as they continue to use it and tolerance develops, the effects are going to be minimized. So again, this is also why we want to prescribe in low doses and titrate up very slowly. And also, again, remembering that the largest portion of the daily dose should be at bedtime to minimize those CNS type side effects. Other less common side effects are bone marrow suppression. We might see aplastic anemia. It is also teratogenic, just like phenytoin was. It does inhibit renal excretion of water, so consider that with patients that may have fluid overload. You might have some photosensitivity, and then just like the other medication, phenytoin, Stevens-Johnson syndromes, 10, DRESS, it's all going to be a risk factor for those dermatologic disorders. There are some significant drug and food interactions to talk about because it does induce hepatic drug metabolizing enzymes. It will increase the rate at which the other drugs are inactivated. So think about what other drugs the patient is on. It does have an accelerated inactivation of oral contraceptives, just like phenytoin. So you might have to think about double contraceptives or changing that contraceptive method. And then warfarin as well will have a change in the way it's being metabolized. And then, just like we've discussed in previous chapters, grapefruit juice can inhibit the metabolism of many drugs, and thereby plasma levels can rise of the drug. So, grapefruit juice can increase the peak and trough levels of Tegretol by up to 40%. So, you want to avoid grapefruit juice. Valproic acid is the last of the traditional anti-seizure medications that we'll discuss today. And oftentimes it can be available in three different forms. We have valproic acid, we have the sodium salt of valproic acid known as valproate, and then we have divalproex sodium, which is a combination of valproic acid plus its sodium salt. And all three forms have identical anti-seizure actions. It's just what is available on the formulary or in the facility that you're working in. The mechanism of action is still widely unknown, but the suggestion is that it's augmenting that inhibitory influence of GABA, and it increases GABA concentration in the brain. We do use this as a first-line drug for partial and generalized seizures, but also we've talked about valproic acid before. You might have read it in your textbook. We use it for management of bipolar disorder and also migraine headache prophylaxis as well. You do also want to consider what the therapeutic range is. Often, this is going to be in plasma levels between 50 to 100 micrograms per milliliter. And the correlation between plasma levels and therapeutic effect is not as narrow as you saw with phenytoin. The adverse effects that you're looking for is primarily you might have some sedation and cognitive impairment, but patients like this medication over the other ones because it usually is more tolerated. It's well tolerated, and the minimal sedation and cognitive impairment makes it, something that they'd rather deal with. However, there are some GI effects that are very common, like the nausea and the vomiting. Hepatotoxicity and pancreatitis are rare but serious. So if you already have a patient that is at risk or has those disorders, then valproic acid would not be the drug for them. Fatal hepatic failure has occurred. Young children and patients with any type of mitochondrial disease are at an increased risk for this medication. And again, remembering that valproic acid is another drug that is teratogenic. So you've seen now all three of the traditional anti-seizure medications have been teratogenic, and you would not want to prescribe this to a patient that is pregnant or trying to conceive. Last thing to note, again, I just want to call it out again, the more common symptoms, even though this is tolerated very well, are nausea, vomiting, anorexia, and abdominal pain, so GI related. All right, now we're going to go into the newer AEDs, and then we're almost done with this lecture. The first drug is called oxcarbazepine, and it looks very similar to another drug we talked about, but the OX in the beginning makes it a different drug by name. It is a newer drug. It's, again, to go back and think about why we would want to use one of these newer drugs. It is better tolerated. And although we don't have as much information, the efficacy and the tolerability of these drugs are positive. There are some additional recommendations if you're very interested in these drugs and how to treat for epilepsy. The American Academy of Neurology and the American Epilepsy Society does take a look at these newer drugs very often, and we are still waiting to see year after year with more information and more patients that have been diagnosed and treated with these newer drugs, what the verdict is on how we should manage our patients with these newer drugs. This drug here, Oxtellar, is its brand name. It serves as the prototype for these newer anti-seizure drugs. And for that reason, we're probably going to spend more time talking about this drug. It is a derivative of carbamazepine. So it does look very similar in terms of the name because they share some features that are the same. We'll first look at the mechanism of action. This also is because it blocks the voltage-sensitive sodium channels in those neuronal membranes. It stabilizes those hyperexcitable neurons, suppressing seizure activity and the spread of seizure activity. This drug does not work on the GABA receptors. It's indicated both as monotherapy, but sometimes you can use this in conjunction with other drugs for the management of partial seizures. And we can use this for adults and children. As monotherapy, though, keeping in mind that, if you're using this by itself, we can use it for children 4 years and older. As adjunctive therapy, you can prescribe this to children as young as 2 years. So a little bit different, safe up to 2 years, but only if you're using it with something else, and then approved for monotherapy for 4 years and above. In Canada, this is just a side note, it's approved for children 6 years and older. So they have a little bit of a different standard. In terms of the central nervous side effects, we have a less of a side effect profile than our traditional AEDs. However, you might see dizziness, drowsiness, double vision, nystagmus, headache, nausea, vomiting, and ataxia. And patients should avoid any hazardous activities while they are on this medication because it can make them very sleepy. But the degree of drowsiness is pretty low, just in case. You want to make sure that they understand that it can happen. Also, there is clinically significant hyponatremia, so lower concentrations of sodium that can develop in less than 3% of our patients. But some signs and symptoms that may tell you that your patient is experiencing hyponatremia from their medication are nausea, drowsiness, headache, and confusion. If this drug is combined with other drugs that also decrease your sodium levels, so think diuretics, then you may need to monitor sodium levels a little more closely. There are some dermatological effects as well. It can cause serious skin reactions like Stevens-Johnson syndrome and TENS, and 30% cross sensitivity among patients with hypersensitivity to the other medication, carbamazepine. So if they've already had some adverse dermatological effect using that medication, you might not necessarily want to switch them over to this medication. They may have a very similar sensitivity. Hematological effects that you want to consider are trying to, first get routine monitoring of their blood counts is really not going to be required because severe hematologic abnormalities are less common here than with its like medication, carbamazepine. You aren't going to see them as much. But in most cases, or excuse me, in both cases, you may notice some pallor, some fatigue, some weakness. And so you might want to get a CBC and see if there's any changes with their hematologic system. Also, hypersensitivity effects that were associated with this medication were serious multi-organ hypersensitivity reactions, and you might see lymphadenopathy, pruritus, hepatitis, nephritis, and oliguria is another symptom you might notice, and we've already talked about the hematologic abnormalities. If any of these things happen, you definitely want to discontinue the medication. There is a significant drug interaction with phenytoin. Because oxcarbazepine inhibits the enzymes that metabolize phenytoin, and it's going to raise phenytoin levels, you may not want to combine this. Also, conversely, phenytoin can decrease the serum levels of this medication. So in combination, you can cause subtherapeutic levels of this medication and also an increase in the phenytoin level, causing phenytoin toxicity. If you do, for whatever reason, need to have this combination and your neurologist is using this combination, then you have to really monitor these dosages and watching for their plasma levels very, very closely. Again, not something you probably want to do on your own in primary care. There are some other drugs like phenobarbital and valproic acid that can increase the levels of this medication. Actually, they decrease the levels of this medication, phenobarbital and valproic acid. Verapamil can increase the serum levels of this medication. Alcohol can intensify CNS depressions that is already caused by this medication. So again, this should be avoided while taking this anti-seizure medication. We're moving on to the last couple drugs. This one is pregabalin. This is also a newer anti-seizure medication. You may have heard a commercial for Lyrica. It's an analog of GABA, and it's very much like gabapentin. However, pregabalin or Lyrica does not bind with the GABA receptor. And it's not going to bind with the benzodiazepine receptor either. So it doesn't work by mimicking or enhancing the inhibitory actions of GABA. And yet, we still don't know what the precise mechanism of action is. We do know that pregabalin can bind with calcium channels on the nerve terminals. And by doing that, it really is inhibiting calcium influx. If we do that, then we are releasing the other neurotransmitters like glutamate, norepinephrine, and substance P. And this is what's thought to create the therapeutic effects from this medication. It is used for seizures, but we know we can also use pregabalin or Lyrica for neuropathic pain, and that's primarily what you'll see the commercials for on TV. Pregabalin has 4 approved indications. We already talked about that neuropathic pain, but also that of diabetic neuropathy. But we can also use it as post-herpetic neuralgia therapy, fibromyalgia therapy, and then here we're talking about the therapy for the use of partial seizures. Some adverse effects to think about, the most common are dizziness and somnolence, and it does persist as long as the drug is taken. So like the other drugs, it's not like it wears off over time, it will persist. So if your patient does not like that overall sleepiness and dizziness, this is not the drug for them. Now, this doesn't mean that all patients are going to present that way, but if they do, it's not something that's going to wear off. Blurred vision may also develop early on in the therapy, but blurred vision will usually resolve over time. So they will build a tolerance and you won't get that side effect. Up to 8% of patients experience significant weight gain of about 7% or more of their body weight. So if weight is important to them or part of their health risk profile, this might not be the drug either, or at least you need to talk about that with your patient. Other adverse effects include difficulty thinking, headache, peripheral edema, and dry mouth. You also may want to consider some other types of reactions, and this has to do more with what consumers have said, but it hasn't been really put out by the pharmaceutical companies. There have been some reports of angioedema, and so we have swelling in the face, lungs, tongue, lips, gums, throat, and larynx. Also, be aware that because angioedema can also be in conjunction with other hypersensitivity reactions, you might want to look for blisters, hives, rash, difficulty breathing, and even wheezing. In clinical trials, there have been patients, although a very low number, that have developed rhabdomyolysis. It is something to consider. In contrast to the other anti-seizure drugs, this drug, pregabalin, is regulated under the Controlled Substance Act. And in clinical trials, up to 12% of patients reported a sense of euphoria as a side effect. And so when given to recreational users of sedative hypnotic drugs, pregabalin produce subjective effects perceived to be the same as a patient taking Valium or diazepam. So it is DEA classified as a Scheduled 5 under the Controlled Substance Act. Any abrupt discontinuation of pregabalin can cause insomnia, nausea, vomiting, diarrhea, and even other symptoms that may suggest physical dependence. And so to avoid these withdrawal symptoms, you want to discontinue very slowly over a week and even more. And then the last things to consider here are, well, a couple things. First, the reproductive risk for men and women. It has been demonstrated to have an adverse effect on reproduction. Also, it has had an adverse effect on fetal development. It does interact negatively with alcohol, opioids, benzodiazepines, and other CNS depressants. These can all intensify that already depressant side effect of pregabalin. So you do not want to combine these things with this newer anti-seizure medication. Pregabalin does not inhibit cytochrome P450, however, but it does not mean that it doesn't interact with other medications. You still need to look at your micromedics or your Hippocrates to see if there's any cross interactions. Something also to note with pregabalin, which is a positive for this drug, is it's not going to interact with oral contraceptives. And so that might be something that is positive for your particular patient. This last drug here is Keppra. And Keppra is a unique agent. It's a newer anti seizure drug, and it is chemically and pharmacologically different from all the others. And how it actually works is unknown. It does not bind to receptors for GABA or other neurotransmitters. So it's still very unclear how levetiracetam actually works, or Keppra. Here in the US, it is approved for three things. It's approved for the use of monoclonic seizures in adults and adolescents, and this is 12 or older. We can also use it in partial onset seizures in adults and children 4 or older. And then and that is for adjunctive therapy, but it can also be used as adjunctive therapy as primary or for primary generalized tonic-clonic seizures in adults and children 6 or over. You may have noticed that Keppra is used off-label as well for migraine headaches, bipolar disease, and new onset pediatric epilepsy. In Europe, it has been approved for monotherapy for partial seizures and has been shown to be highly effective. There are some potential side effects to think about, and usually they are generally mild to moderate, and the most common being drowsiness and the lack of strength or weakness, also termed asthenia. Neuropsychiatric symptoms also may occur, like agitation, anxiety, depression, psychosis, hallucinations, but it usually will happen in less than 1% of patients. And unlike the other anti seizure drugs, this drug is not going to impair speech, cognition, or concentration. Another positive for this drug is that Keppra does not interact with other drugs. It does not alter plasma concentration levels of oral contraceptives, warfarin, digoxin, or other anti-seizure medications. So again, if you're wondering why you would pick this medication, even though we don't really know the mechanism of action, that is why. You're going to have just less side effects, and the benefits are primarily attributable because it's not being metabolized by the P450 isoenzyme. The last handful of slides in this slide deck are all coming right from your textbook. I've just wanted to highlight some important information for you to take some time and review. So go ahead and pause the presentation and go over each of these slides. This first one is patient education, thinking about just generally what to tell your patients about anti-seizure medications. So just off the bat, talking about having to establish a baseline for lab results, and then they may have to come in periodically to measure plasma levels. Most of these drugs you would not want anyone driving or operating dangerous machinery on. It can make them very tired, and you might even want to recommend having some type of medical bracelet so that anybody could know that they were on these medications, especially since there's so many side effects. And it also lets people know in case of an emergency that they do have a seizure disorder. This next one is talking about patient care across the lifespan and looking at how you would appropriately educate your patients and use patient-centered care, going from childhood to breastfeeding to pregnant women and our older adults. And I would even take a deeper dive in the Beers criteria, which you will see lists some of these drugs as inappropriate for anybody over the age of 65. Please pause and read this thoroughly for your patient education. Here you're seeing just a summary of overall key prescribing considerations. Again, knowing that our therapeutic goal is not to completely stop the seizures in some cases or cure the epilepsy, but really we're trying to minimize the seizure events as possible and try to eliminate the seizure if we can. But usually this is going to be a balance with their tolerance for the adverse effects. Get baseline data. Start with the pregnancy tests. Most of these anti-seizure drugs are going to react or interact with oral contraceptives, except for a couple. And also conduct a depression screening as well, because we've seen that some medications do increase the risk of suicidality and depression. And then also, because is a depressant effect on the medication, you want to get a baseline of where the patient's mental health is prior to using these medications. And then here are some additional baseline information. For most of these drugs, you do want to check a liver and renal panel and a CBC. And then for those that do have a risk for Stephen Johnson's or TENS, if they're of Asian ancestry, or if they carry the HLA-B, HLA-B 1502 allele variant, then they may be at higher risk for the symptoms of DRESS syndrome. To monitor your patient ongoing, again, using the same technique of getting baseline labs, but you will also here stop and pause and look at the continual assessment for that patient. And then the high risk drugs, looking again from medication to medication, who is contraindicated, who should not take a particular medication, and try to organize this too in your head, like which are the newer versus the traditional medications. This last slide here is dedicated to how we minimize the adverse effects of our patients, ranging from their CNS depression, withdrawal seizures, usage in pregnancy, suicidal thoughts, and behavior. So more patient education and more education for the prescribing provider.